All right, welcome back. So last time we started the peripheral nervous system. This time, hopefully it'll be a little bit shorter. We're just going to talk about the cranial nerves today. So hopefully you'll remember that nerves are bundles of axons in the peripheral nervous system that relay information either away from or back to the spinal cord, or in the case of the nerves that we're talking about today, either away from or back to different parts of the brain. So the cranial nerves, as you can see there, there's 12 pairs of them. So there's one on the right and one on the left. That makes up a pair. They're numbered 1 through 12 using Roman numerals. And what's special about the cranial nerves is that they either originate from the brain or from the brain stem. And how that's different from the nerves that we're going to talk about next time is all the rest of the nerves arise from the spinal cord. So these 12 nerve pairs that we're talking about today all originate either directly from the brain or from the brain stem. And so we'll go through them in order. So we're going to, like I said, they're numbered 1 through 12. We'll go through them in order. And in terms of, so I'll give you both their number, obviously, and then their name as well. In terms of the naming for them, as you can see there, so the names for the nerves are named in the same basic way that a lot of things anatomically are. So it can be either related to the function of that nerve. So for example, the abducens nerve moves your eyes side to side. So if we abduct something, we take it away from the body or we move it laterally. And so the abducens nerve is responsible for innervating the muscles that move your eyes from side to side. So it's named for the function in that case. Sometimes they're named for where they run. So for example, the hypoglossal nerve is named because it actually runs underneath the tongue. So glossal is tongue and hypo is below. So the hypoglossal nerve runs below the tongue. Other nerves like the vagus nerve comes from the same root word as vagabond, which means wanderer, right? Because the vagus nerve actually is the one of the cranial nerves that leaves the head and neck region and it wanders down into the thorax and abdomen. So it's named for where it goes in that case. So we'll start obviously with cranial nerve 1. Oh, before we move on to cranial nerve 1, here's a little table. That table will probably be useful for you. This is in the slideshow that's posted in Canvas, or obviously you could just pause the YouTube video. But what this has is all 12 cranial nerves, as you can see, and has whether or not they have a sensory function, because as you'll see, like with the abducens nerve I mentioned a minute ago, there's no sensory function to it. But does it have a motor function? Yes. And then does it have autonomic fibers is essentially what this is. So this is a handy little table to be aware of. And then, without further ado, on to the first cranial nerve, which again is the olfactory nerve. So on each of these slides, you're going to see, is there a sensory function? If so, what is it? Is there a motor function? And then on some of them, they're broken down into somatic motor function or autonomic motor function. Remember that the difference between the two is somatic motor functions are voluntary motor functions. So they're things that I can consciously think about and do, as opposed to autonomic motor functions are ones that happen automatically. So it's muscle contraction that occurs without me ever thinking about it. So that might be activation of glands, causing them to secrete mucus, causing them to secrete saliva, those kinds of things. Or that may be, as you'll see here in a second, the role of involuntary muscles in dilating the pupils or in moving the lens, either stretching or allowing to contract the lens of our eye that helps us focus on things. So that would be an autonomic motor function. And then the last thing I have on there is, on each slide, is clinical testing, which is how you would assess whether or not this nerve was functioning correctly. So one of the reasons that I put this on here is oftentimes students in this major want to go into physical therapy, athletic training. Sometimes people are interested in going into orthopedics or chiropractic. And so at times you may have to assess the function of the cranial nerve. So from an athletic training standpoint, because again that's where I have most of my experience, when you would assess cranial nerves is oftentimes on the sidelines after a potential traumatic brain injury. So after somebody gets a concussion, there's a number of things you do with them. You ask them questions, can you remember what you had for breakfast? Remember these 3 words for me, those kinds of things. But in addition to that, you'll also have them do cranial nerve assessments. You'll have them do things like follow your finger as you move it around, follow your finger with their eyes. or you'll have them read things, or you'll have them stick their tongue out or make facial expressions, those kinds of things. And what you're trying to assess there is whether there's cranial nerve damage, because if there is, then obviously you need to refer them for further evaluation. So you may have actually done some of this cranial nerve testing if you yourself suffered a concussion, and you may remember doing some of this stuff. So that's what the clinical testing is. So we'll talk about assessing the function of each of these nerves as we go along. So as mentioned, cranial nerve 1 is the olfactory nerve. Remember that olfaction is smell. And so the olfactory nerve is only a sensory nerve. So again, throwing it back to last time's lecture, I talked about that nerves could either be afferent, which is sensory, or efferent, which is motor, or they could be mixed nerves, which means that they're both. So in this case, the olfactory nerve is only an afferent nerve, so it's only sensory. There's no motor function to it. It doesn't cause any type of muscle contraction. And so the olfactory nerve is actually connected to the olfactory bulb, which then has these little filaments that shoot off of it, and they go down through the ethmoid bones. Remember, we talked about the ethmoid bone, we talked about the bones of the axial skeleton, or the bones of the skull more specifically, and that it had little perforations or little holes in it to allow these filaments to pass through it. And so these little filaments pass into the nasal cavity, and then when they pick up certain chemicals, so like perfume, for example, that causes them to depolarize. And so then the brain interprets that that chemical information as meaning that you're smelling a particular perfume, or you're smelling barbecue, or whatever it is that you're smelling, right? So the olfactory nerve then, its function is smell, and it actually, so it goes from the olfactory bulb here into the olfactory tract, as you can see, which ultimately synapses in the primary olfactory cortex, which is located in the temporal lobe of the brain, which again, hopefully you remember, is kind of right behind your ears, or medial to your ears is probably a better way of describing that. So if we want to assess if someone's olfactory nerve is functioning, we will ask them, can you smell this? And so from a practical standpoint, if you're doing a sideline assessment, normally what you ask them to smell is something like a cough drop, because usually those have a pretty strong cherry smell, or whatever flavor you happen to buy. All right, second cranial nerve is the optic nerve. So as you probably know, optic means eyes, and so the cranial nerve, the optic nerve innervates the eyes. So as you can see, this one is also only an afferent, only a sensory nerve. So its function is vision, and so each eyeball has an optic nerve. And so those two actually converge here at this area called the optic chiasma. And then some of the fibers cross over. So some of the fibers from this guy's, because you're looking at, in this case, this is an inferior view of the brain. So this is actually this person's right eyeball. So some of the fibers from this person's right eyeball cross over to the left side of the brain, and then vice versa, but not all of them, because you can see these fibers from the right eyeball actually stay on the right side of the head. So some of the fibers cross over at the optic chiasma, but not all of them, and then they go back here and synapse in the thalamus. So remember that the thalamus is the relay center of the brain. The vast majority of sensory information coming back from the body synapses first in the thalamus and then goes somewhere else, and so that includes a lot of our visual information. So the visual information then goes to the thalamus, and then from the thalamus, you can see that there are fibers that go back here into that visual cortex in the occipital lobe, where we put together the patterns of light and dark and color, and then we make meaning from that information. So as mentioned, no motor function for this nerve. In terms of clinical testing, the standard way to test this is asking the athlete, or asking the individual, if they can read something. So you have them give them like a medicine packet or something like that, and ask them to read the instructions, or something fairly straightforward, just to make sure that their vision is still functioning correctly. Now, obviously, if you get pretty significant damage to the optic nerve, that can result in blindness, which is something that the athlete would probably report to you that they can't see. But there might be some more subtle indications of damage to the optic nerve, where it's not full blindness, but there's, maybe the letters look blurry or something like that, that might give us an indication that potentially there's some optic nerve damage there. So the testing is you have them read something. Next one is the oculomotor nerve. So the oculomotor nerve is one that tells you what it does. So it literally means eye mover. And so, as you can see, this one is only an efferent nerve. There's no sensory function. So, and from a motor standpoint, there is somatic motor activity, which again, remember, that's voluntary movement. So in this case, it's voluntary movement of 4 of the 6 extrinsic muscles of the eye, as well as the eyelid muscle. And so this one is the primary mover of your eyeball. So whenever you are looking up or down or left or right, etc., this controls most of the muscles responsible for doing that. In addition to that, so that's the somatic function, because obviously I can think about and voluntarily look up or look down, etc. So that's somatic function, as opposed to autonomic. Remember, that's automatic. And so pupil constriction, where we close our pupils down to let in less light. So you see pupil constriction when you go out and it's really bright outside. Your pupils will reflexively constrict. You don't have to think about that. They just do that. And so that's an autonomic motor function. And then, as you can see there, it affects the lens shape. And so that either stretches the lens or relaxes the lens or causes muscles to contract, that when they contract, they either stretch the lens or they allow it to relax a little bit. And so that plays a role in your ability to focus on something either far from you or near to you. So the autonomic roles then, pupil constriction, restricting the amount of light that enters the eyeball, and then your ability to focus. So in terms of clinical testing for this one, so the first one there is pupil reaction. The way that you would test that is you use a pen light, and you have to put your hand over their face, kind of like a baseball cap, the visor on a baseball cap. So you shield their eyes from a lot of the external light, and then you take your pen light, and then you go from the side in front of their eyeball, and you make sure that their pupil constricts. And you also want to make sure that both of their pupils are even. They probably will be if you're talking to them on the sideline, but while you're at it, you want to check that out. And so that's the symmetry aspect. So you make sure that both pupils are equal and reactive to light. So the acronym for that is PERL. Pupils are equal and reactive to light. And then you would also ask them to blink their eyes and then to follow your finger or follow your pen light. And so this is actually, if you've ever seen like a side-of-the-road DWI test, same basic test. And so what you do, so again, you check pupil constriction, and then you take your pen light and you go up. So you have them, you tell them, don't move your head, just follow my pen with your eyes. And so you move the pen up, move it down, side to side, and then you kind of make an asterisk. So you go at 45-degree angles and see if they can do that. And there are 2 other nerves that we're about to talk about that also innervate extrinsic muscles of the eye. And so those are cranial nerves 4 and 6. And so those 2 are going to be tested as part of this follow my finger test. So while you're doing the follow my finger test, not only are you testing cranial nerve 3, but you're also testing cranial nerves 4 and 6. If somebody gets damage to the oculomotor nerve, the most obvious signs of that are typically that they have a drooping of the eyelids. So again, because it's the muscle that's responsible for the eyelid, if that muscle isn't innervated, the eyelids don't function correctly, so their eyelids tend to be kind of droopy. Or they may have double vision, which would be indicative that the lens isn't functioning correctly, or trouble focusing on objects either near or far. And so that's also kind of where the reading test from cranial nerve 2 comes in. So there's some overlap between cranial nerves 2 and 3 in terms of the testing, because we want to see if they can focus on that little medicine packet or whatever it is that you're having them read. Cranial nerve 4, the trochlear nerve. So trochlear means pulley, and it's named that because it innervates an extrinsic eye muscle that loops through a pulley-shaped ligament in the orbit. And so you can see that ligament up here. So no sensory functions of this one. This one's only a motor nerve, and its only motor function is somatic, so it's only voluntary motor function. And so it's going to control the muscle that rotates the eye down and away from the midline. So that's inferolaterally, so down and away from the midline. Similar to cranial nerve 3, this one is going to be, in terms of damage to it, this one may result in double vision, in part because you can't move the eye quite as you want. But particularly, it's going to result in the ability they can't move their eye down or to the side very well. And you'll see that this one crosses over with the abducens with cranial nerve 6, because it also moves the eye to the side. So on the clinical testing here, you can see we're going to test it with cranial nerve 3 with the oculomotor nerve, because again, those control the voluntary muscles of the eyeballs, and so they allow us to move our eyes up and down, side to side, etc. So the nerves that control the eyes, or the muscles, the extrinsic muscles of the eyes, are broken up here by the trigeminal nerve. And so the trigeminal nerve, the name actually comes from the structure of the nerve. So it has 3 divisions to it. And so those 3 divisions are the ophthalmic division, the maxillary division, and the mandibular division. And so you can see the divisions there, but it's better illustrated here because they innervate, they provide sensation for the face and head, or scalp is usually the way this is described. So the first one there, VIII, is that first division of the trigeminal nerve. And so that is the ophthalmic division because it's near your eyes. And so it provides sensation for, as you can see, your nose, your forehead, around your eyes, and then the top of your head. And then the maxillary division, remember that your maxilla is that bone there that your upper teeth are held in, but also forms part of the orbit of the eye. So this one runs kind of in that maxillary region. And so the maxillary division here is going to be responsible for this part of the face. And then remember that your mandible is your lower jaw. And so the mandibular division provides sensory information about all along the mandible, and then also up here onto the kind of the parietal area of the skull. So it then provides sensory information, and you can see there the type of sensory information: touch, pain, temperature, for the face and the anterior scalp. It does have a motor function. So remember back when we talked about the axial skeleton, we talked about a really large muscle on the side of the skull that covers parts of the parietal bone, temporal bone, and frontal bones. I think also the sphenoid. Pretty big origin there on the lateral aspect of the skull. Inserts on the mandible. That muscle is the temporalis muscle. And so that is your primary chewing muscle. It's gonna elevate or pull up your mandible to help you compact or crush food in your mouth, and then also retracts your mandible, moves it slightly backwards some. So from a motor standpoint, the trigeminal nerve innervates the temporalis muscle, which is your primary chewing muscle. So in order to assess whether or not this nerve is functioning correctly, we'll start by having the athlete close their eyes, and then you can just apply, light touch to the 3 different parts of the face, so kind of along their eyebrow ridge, along their cheekbone, and then along their lower jaw. Can you feel this? Yes. What's it feel like? Just make sure it's normal. And then you can ask them to open and close their mouth, and then to move their jaw side to side. So again, we're checking the function of those chewing muscles. If they can't do that jaw movement, then we would assume that potentially there's some problem with the trigeminal muscle. So from a motor standpoint, you probably would have known, but the motor function here is only somatic. It's only voluntary. There's no autonomic function there. Now back to the eye muscles. So cranial nerve 6, that's the abducens muscle. And so the way that I always remember this one is, again, if you abduct something, you take it away from the midline, which is kind of moving out toward the side. And so this muscle, or this nerve, innervates the muscles, there we go, that move your eyes side to side. So they move your eyeballs laterally. So the abducens nerve innervates the muscles that move your eyes to the side. So then that makes the name make a little bit more sense. From a sensory standpoint, nothing with this one. So it's only an efferent, or only a motor nerve, and it's only a somatic motor nerve, so only voluntary. So as mentioned, we're going to test it with the oculomotor nerve. So as part of the whole follow my pen thing, you're going to move side to side, and so you'll be evaluating the abducens there while you do that. All right, facial nerve. So the facial nerve is one that is named because it innervates the musculature of the face. So that gives you some idea of the function based on the name there. So there are 5 major branches to this one. So this one branches quite a bit, and you can see the branches there, and again here, but they're a little bit clearer in this little easy to remember thing. So the 5 branches there, you see the temporal branch, or the temporal branch there near the temporal bone. Remember that your temporal bone kind of takes up this lower area on the side of your head. So the temporal branch is right there. The zygomatic, remember your zygomatic bone's your cheekbone? So the zygomatic branch runs pretty close to your cheekbone. Buccal can either mean cheek or mouth. So the buccal branch is close to your mouth. Again, the mandible is your lower jaw, and then the cervical section, remember your cervical section of your spine is your neck, so that's the lowest of the branches. So in terms of what it does, so you can see that it has both somatic and autonomic motor function. From a somatic standpoint, it controls the muscles of facial expression. So when you smile or frown or furrow your brow, all those kinds of things, the muscles that make those expressions are innervated by the facial nerve. From an autonomic standpoint, it produces secretions, basically. So it's going to stimulate tear production, so from the lacrimal glands, and then from the next two sets, so from the nasal glands and the palatine glands. Remember that your palatine bone is at the back of the mouth. So remember that most of the roof of your mouth is made up from the maxilla, but just posterior to the maxilla is the palatine bone or palatine bone. And so the palatine or palatine glands are mucus glands, essentially at the back of the mouth. So it stimulates mucus secretion from the glands in the nasal cavity, also the palatine glands, and then stimulates production of saliva as well. So basically, from an autonomic standpoint, the facial nerve then initiates secretions, whether those are tears or saliva or mucus. Fun stuff. All right, and then from a sensory standpoint, it innervates the anterior, so the front 2/3 of the tongue, and so it plays a really important role in the sensation of taste. So the way that we assess that then is that we're going to check their ability to taste things that are sweet, sour, bitter, or salty. Normally the way from a practical standpoint this is done is you actually just give them the cough drop that you had them smell with the olfactory nerve. Just say, okay, close your eyes, I'm going to give you something, put this in your mouth, tell me what it tastes like. And so they'll hopefully say, oh, it tastes like cherry, just like that cough drop you had me smell a little while ago. And so then you'll know that the sensory component of their facial nerve functions. And then also you want to check the somatic motor functions. So you'll say, okay, can you smile? Can you frown? Can you furrow your brow? Just have them make a couple different faces just to ensure that the somatic motor function is intact. And then I have a quick case study for you. So the case study is, we're going to pretend that you're a high school coach, and one of your athletes, who is a 14-year-old female softball player, reports to first period, and you notice that something is a little bit off with this athlete. You ask her if she's feeling okay, and she says yes, other than that her face feels funny. Since she woke up this morning, she noticed that the left side of her face doesn't work quite right. When she drinks, water dribbles out the left side of her mouth, and as she's telling you this, you notice that the left side of her face doesn't move very much when she talks. She also says she didn't really taste her breakfast much and hasn't been able to fully close her left eye. And when you look at her closely, now that she's kind of complained of these things, her face looks like this. Right? So there's an obvious difference between the right side of her face and the left. The left side of her face really is just lacking in tone. So you can see it's just kind of, as I titled my case study there, somewhat insensitively, but the left side of her face appears just kind of droopy, right? There's a lack of muscle tone on the left side of her face that's still present on the right side. So there's something different on the left side of the face than there is on the right. So what could be happening here? Well, the particular condition this person has, this athlete has, is called Bell's palsy. And it's actually a fairly common condition. So what happens in Bell's palsy is that there's a swelling of the facial nerve. And so remember, we're talking about cranial nerve pairs here, so it usually just affects one side, not both sides of the cranial nerve. So they'll have symptoms, in this case, on the left side, so it's usually just a unilateral issue. So when that nerve swells, because of the small passage that it goes through in the skull, that then impairs its function. And so because it has both motor and sensory function, the more obvious of the two is the lack of motor function. So remember that your facial nerve is responsible for allowing you to do things like smile and frown and make all those facial expressions. And so that lack of tone of her facial muscles there is due to a lack of input from the facial nerve. It's not functioning correctly. The outflowing signals from the brain can't get to those muscles because of the swelling of the nerve. And then one of the other things I threw in there was that she mentions that she didn't taste her breakfast very much. So remember that the facial nerve also has that sensory function, innervates the anterior 2/3 of the tongue, and so she wouldn't taste her breakfast because she was only she would have tasted some of it because the posterior part of the tongue is innervated by another of the cranial nerves that we'll talk about here in a minute. But it would have just been less pronounced because effectively 2/3 of the messages from the taste buds weren't getting back to her brain. So there would be some taste there, but not much. And so I mentioned that it was common. Well, what causes it? Typically, it's caused by a viral infection. The most common virus that causes this is the herpes simplex 1 virus, which is the same one that causes cold sores in your mouth or fever blisters in your mouth. But sometimes that same virus can affect the facial nerve. And so that swelling of the facial nerve then, again, causes all the problems that we talked about. So the good news is this one's typically treated with anti-inflammatories, specifically corticosteroids. And so with those treatments, almost everyone achieves a full recovery. So typically the symptoms go away after a few days. Whenever you take anti-inflammatories, you allow the swelling of the facial nerve to recede, and then its function returns. All right. Cranial nerve 8. So the vestibulocochlear nerve. So anything cochlear deals with your ear. Anything vestibular deals with your balance. So the vestibulocochlear nerve is a nerve that is responsible for relaying information about balance, specifically about head position, and then about sound. So from a sensory standpoint, I'll come back to motor. From a sensory standpoint, there's 2 branches to this nerve, and you can see them here. So there is the cochlear branch right there, the more inferior of the 2, and then there's the vestibular branch through here. And so the vestibular branch goes to these things, the semicircular canals. They're filled with fluid, and you have little specialized hairs in here that whenever you move your head, whether you look to the left or right or up or down, whatever it is that you do, that moves the fluid around in these semicircular canals, causes deflection of the hairs, and then that generates action potentials that travel via the vestibular branch of the vestibulocochlear nerve back to your brainstem, and then that helps us to process how our head is moving in space. It gives us some idea. So it plays a role in proprioception as well, so knowing where we are in space. So that's the vestibular branch. And then the cochlear branches transmit sound information back to the brain. So from a motor standpoint then, it's an autonomic function in this case, because you can't intentionally reduce the sensitivity of your sound receptors. So it's an autonomic function there, but you can see there that the autonomic function is that it can adjust the sensory of the sound receptors. So if there's damage to this nerve, the common symptoms are, well, if it's the cochlear branch that's damaged, if it's really damaged, you're going to get deafness. And then if it is the vestibular branch, they're going to have a feeling of dizziness or vertigo, just like, like the floor is moving, they're completely off balance. And then that tends to produce a sensation of nausea and then potentially vomiting because you just feel like you're off balance all the time. It would probably feel like you were on a boat, out in choppy waters, right? So in terms of clinical testing for this, so to test their hearing, you've been instructing them to do a bunch of things up to this point while you were testing the other nerves, so you probably have a pretty good idea whether or not they can hear. But if you want to build on that, on what you've already done, you can test their hearing on one side or the other. Just have them close their eyes, and you can snap your fingers on one side or the other and have them identify which side the sound happened on. So that's one way to assess that. Balance, there are some pretty detailed balance tests. So there are some where you have them stand on 2 feet, stand on 1 foot, have their feet one in front of the other, and then maybe put them on a balance pad, and there's a whole scoring system that goes along with those. But usually what you have them do on the sideline is just stand there, potentially with their feet together, and say, okay, just stand there and hold your position. Then you have them close their eyes, see if they can do it, and then if you want to throw in more difficult stuff, you can have them put 1 foot in front of the other or have them pick up 1 foot. But what you're looking for is that their balance is relatively normal, that they can stand there with their eyes closed without falling over. Now, I should mention that if you're going to do the balance testing, you're supposed to do balance testing at the beginning of the year, and that way you can see what's normal for them. Some people, as you know, just have bad balance, and so you don't want to misdiagnose and be like, oh, potentially they've got some vestibulocochlear nerve impairment, when it turns out they just have really bad balance. They're not a very good athlete. So that's how you assess that one. All right, cranial nerve 9, the glossopharyngeal nerve. So you can see this one has both motor and sensory function. In terms of motor function, also has both somatic and autonomic function. So somatic function is that it elevates the pharynx during swallowing. So the pharynx is essentially the posterior part of your nasal cavity, the posterior part of your mouth, and then it goes down your throat. There's actually 3 parts to the pharynx. But whenever you swallow something, there is a somatic function in that. There's a voluntary function in that where when you decide it's time to swallow something, you elevate the pharynx a little bit, and some of these muscles actually widen the pharynx to allow the food to go into that opening more easily. And then when we elevate the pharynx, what that also does is it closes something called the epiglottis, which is a little flap that goes across your larynx. So basically it keeps food from going down into your lungs, keeps you from aspirating or moving into your lungs, whatever it is you were swallowing. So from a somatic standpoint then, elevates the pharynx, so it plays a role in swallowing, voluntary swallowing. And then from an autonomic standpoint, plays a role in producing saliva. Yeah, I don't have to say anything more about that. I was trying to look in my notes and see if there's anything else I want to mention, but that's sufficient. All right, so from a sensory standpoint, so it also plays a role in taste from the tongue as well, mostly from the posterior aspect of the tongue, but it also gives you sensory information from the back of your mouth. So if maybe you swallowed a pill or something and it kind of like got stuck in the back of your mouth or stuck in your throat, that information relaying that to the brain travels over the glossopharyngeal nerve, so it provides sensation from the posterior aspect of the mouth and throat. And then it's also responsible for chemoreceptors, so this is unconscious sensory information coming from the carotid arteries. And so the carotid arteries supply the vast majority of blood to your head. And so those are the ones on either side of your throat. If you take, in other classes, you've probably like exercised and then put your fingers on your throat and felt your pulse increase. Those are your carotid arteries. They're really obvious arteries on either side of the throat. And so in those arteries, you have chemoreceptors, throwing it back to what we talked about last time, that monitor the pressure of oxygen. So that would go down if you, let's say, went to altitude. You'd have a reduced oxygenation of the blood, and the chemoreceptors in the carotid arteries would pick that up, and they would cause you to breathe more often, or they would cause an increase in heart rate. You'd also have decreased oxygenation of the blood if you had problems with your lungs. So things like emphysema, potentially COVID, that then effectively block the surface area for gas diffusion in the lungs. So the chemoreceptors in the carotid arteries sense that oxygenation of the blood. Also carbon dioxide pressure, so the pressure of carbon dioxide goes up like during exercise. Carbon dioxide is a byproduct of aerobic energy production, so you get more carbon dioxide in the blood whenever you're exercising. And then you have something called a baroreceptor, or actually 2 of them. You have baroreceptors on either side in the carotid arteries as well, and so those monitor your blood pressure. So BP on there stands for blood pressure. And so the baroreceptors are essentially the brakes on your blood pressure, and they will increase parasympathetic drive, which is going to slow your heart rate down, and then that'll also reduce your blood pressure a little bit. So from a clinical standpoint, how do we assess whether or not the glossopharyngeal nerve is functioning? The most obvious things are to have them swallow, because again, that somatic motor function is involved in swallowing. And then again, you can assess taste. So obviously this is another one where there's a crossover with another cranial nerve. But that's okay. All right, and then home stretch now. So cranial nerve 10 is the vagus nerve. So the vagus nerve, you can see, does a lot. So it's actually a fairly large nerve with some branches off of it. So the vagus nerve is the only one of the cranial nerves that actually extends beyond the head and neck region, and it goes down into the thorax, which is your chest, and also goes down into the abdomen, so everything below your chest. And so as mentioned at the outset, the name for this one comes from the same root word as vagabond, which means wanderer, because this nerve kind of wanders throughout the body, right? So it innervates things in the head and neck, but then it also plays a role in innervating your heart and your stomach and your intestines, plays a role in digestion. So it does a bunch of different things. So this cranial nerve, again, extends beyond the head and neck region, but it does arise from the brainstem, and so that's why it's still a cranial nerve. So in terms of somatic or voluntary function, so it's also involved in swallowing, as well as speech production. So it controls some of the muscles involved in with the larynx. So it's involved in speech production. So for example, if the vagus nerve is damaged, one of the signs of that would be they have a hoarseness in their voice, or that they can't produce any sort of speech at all. And that would indicate impairment of the muscles of the larynx. So they're not getting the motor impulses that they should. From an autonomic standpoint, we'll actually talk about this nerve quite a bit more with the final chapter with the autonomic nervous system, but it's involved in regulating your heart rate, as well as your breathing rate, and then again it's going to have some influence over gastric motility, so moving things through the digestive system. Because it goes down into the thoracic cavity and also to the abdominal cavity, it provides visceral sensory information back to the brain. So it gives the brain sensory information about what's going on with the heart, the stomach, the intestines, etc. As well as it gives similar information to cranial nerve 9 about oxygenation and oxygen pressure in the blood, as well as carbon dioxide pressure. But the area that information comes from is actually from the aorta, so from the blood vessel, which is conveniently pictured here. So it has chemoreceptors, or it innervates chemoreceptors here in the aortic arch that give us information about blood pressure. That would actually be a mechanoreceptor, but they give baroreceptors give us information about blood pressure, and then has chemoreceptors that give us information about oxygenation of the blood and pressure of carbon dioxide in the blood. So we're going to test this one with cranial nerve 9 because, again, cranial nerve 9, the glossopharyngeal nerve, is also involved in swallowing, so we test those two together. But then you could actually have them say something if you haven't already talked to them a little bit, and just make sure that their voice production is normal. And if it's not, again, that might lead you potentially to think that there's something wrong with the vagus nerve. Another kind of later symptom with the vagus nerve is that there's a reduction in gastrointestinal motility. So they may have constipation or something similar to that if there's damage to the vagus nerve. But that wouldn't show up for a day or two. The accessory nerves, so those are actually accessories to the vagus nerve. So they, they're we'll leave it at that. One of the interesting things about them is that technically they don't arise from the brain, they actually arise from the spinal cord. But because they actually go back up through the foramen magnum, back inside of the skull, and then back out, they are still classified as a cranial nerve. So I mentioned at the outset that the cranial nerves arise from either directly from the brain or from the brain stem, and that the rest of the nerves arise from the spinal cord. Well, the accessory nerves actually arise from the spinal cord, but are classified as a cranial nerve because they go from the spinal cord back inside of the skull. So what do? Their function is only somatic motor, or their motor function is only somatic. So they innervate the trapezius muscles, which hopefully you'll remember, your traps. We talked about those way back with the first lab. Those are your big kind of shoulder muscles that elevate the scapulas, rotate them up, retract them, etc. And then they also innervate the sternocleidomastoid muscles. Those I mentioned, but I haven't actually shown to you. The sternocleidomastoid are muscles on either side of the head that whenever you turn your head to the opposite side, so if I were to look to my left, that would contract my right sternocleidomastoid, and as you look to the opposite side, those muscles become really prominent and will actually kind of poke off of your neck a little bit on sort of the anterolateral aspect. So those are your sternocleidomastoid muscles. So it innervates both the traps and the sternocleidomastoids, so neck musculature is kind of a way of thinking about what the accessory nerves do. And from a sensory function, so proprioceptors, so like the muscle spindles in those muscles. And then clinical testing, what we do is we have them do shoulder shrugs, see if their traps are working, and then you would check whether or not they can turn their head side to side, which is an assessment for the sternocleidomastoid muscles. One of the interesting things here is if this nerve isn't functioning correctly, so the sternocleidomastoids and the traps wouldn't be getting efferent signals causing them to contract. So you're obviously going to get some loss of tone. So you may get that their shoulder kind of droops on the injured side or the affected side. But the other thing is that their head tends to turn toward the affected side. So if the accessory nerve on the right side is damaged, their head tends to rotate toward the right, because if that sternocleidomastoid muscle on the right side isn't getting innervation, isn't contracting, doesn't have tone, then that's a muscle that rotates me to the opposite side. So if that muscle doesn't have tone, I'm actually going to rotate to the same side because of the lack of function in that sternocleidomastoid muscle. And the last one, the hypoglossal nerve. So I mentioned at the outset, runs below the tongue, so that's where the name comes from. The name literally means under the tongue. And so what does it do? It primarily innervates the tongue. So it allows us to move the tongue around and do all the things that it needs to do, like manipulating food in the mouth during chewing and swallowing, and then also the role that the tongue plays in speech production. So it controls voluntary movement of the tongue. It's kind of the short version. No autonomic function here. From a sensory standpoint, kind of like the accessory nerve, the sensory function is just the proprioceptors in the tongue, so knowing where it is in space. And then from a clinical standpoint, if they've been talking, you probably would have noticed if their tongue wasn't functioning correctly, because they wouldn't be able to produce the sounds that they need to produce. There might be like a lisp, or there might be certain things that they need to say, like TH sounds that they couldn't make if their tongue wasn't functioning correctly. So you would probably notice without assessing it directly. But if you want to assess it directly, basically you have them do things like stick their tongue out and go side to side, and just do whatever tongue movements you want them to do to ensure that it's working correctly. I read a case study a few years ago from a collegiate wrestler who got dropped on his head during wrestling practice. I don't know exactly what they were doing, but at any rate, got dropped on his head during wrestling practice, suffered a concussion, but in addition to the concussion, his tongue was kind of stuck to one side. So basically it was sort of stuck forward, and then also I think it deviated to the right. And so that was an indication of hypoglossal nerve damage. I think it was self-limiting. I think it resolved shortly thereafter. But anyway, that's one of the few actual examples I've seen of hypoglossal damage, is basically that the guy's tongue was stuck to one side because he couldn't activate the muscles to move it back to the midline, essentially. All right, so those are our 12 cranial nerves. So there are several mnemonics to help you remember the cranial nerves. This is one of the PG ones. There are some that are not PG ones, but we'll stick with this one. So the mnemonic is: on old Olympus, towering tops, a friendly Viking grows vines and hops. And so you can see there, so there's 3 O's on old Olympus, so that's olfactory, optic, oculomotor, towering tops, trochlear, trigeminal, the A is for abducens, and then our friendly Viking, facial and vestibulocochlear, grows is glossopharyngeal, vines, vagus, and hops, the accessory nerve, and then the hypoglossal nerve. And then in addition to that, if you want to get really in depth, there's another mnemonic that helps you remember whether each of the nerves is either a sensory nerve or a motor nerve or both, so a mixed nerve. And so that mnemonic to figure out if they're sensory, motor, or both is: some say marry money, but my brother believes it's, which is not part of it, bad business to, also not part of it, marry money. So some say marry money, but my brother believes bad business, marry money. And so what that means, so again, some say, so S here for olfactory, so sensory only, marry money, so motor, but, so both, so a mixed nerve, my, which is motor for abducens, brother for facial, so both, a mixed nerve, believes, so both, another mixed nerve, bad, another mixed nerve, business, mixed nerve, marry, motor, money, motor. So if you want to remember whether they are sensory, motor, or both, that's actually the only mnemonic I'm aware of for that. So those are the cranial nerves and how to assess them. In a normal semester, I have a whole thing on how to do that, and we would all do that on each other just for fun, but it's not a normal semester, so that's where I'll leave off today. So those are all the cranial nerves. Next time, we'll get into the spinal nerves, which, good news, don't have names. They are, C1, T5, etc. So they're a little bit easier because they're just like the vertebrae. So the spinal nerves are a little bit easier, no names to remember. And so we'll cover all of those next time, and that'll take us through the rest of the peripheral nervous system. So we'll see you then.